Thanks everyone for joining. I hope everyone could see me. Thank you for joining the New York HIMSS webinar today, where we'll be discussing reimagining healthcare facilities using disruptive technologies. We have a panel of several experts. We have Beth Muller. Beth, why don't you introduce yourself quickly?
Hi, I'm Beth Muller. I'm an information technology engineer with JB&B located in New York City.
John Barto.
Hi, I'm John Barto. I'm a healthcare evangelist with Microsoft, a former CIO from a hospital.
And Roger McClean.
Good afternoon, all. Roger McClean, Director of Design Construction, Memorial Sloan Kettering Cancer Center in New York City.
All right. And I'm Jaimie Fox. I'm a technology strategist from Microsoft. I'm also part of the New York HIMSS chapter and a board member of the New Jersey HIMSS. So let's get started. We're going to start talking about the enhancements of patient experience through disruptive technologies. And we're going to start with talking about wayfinding and location and real-time location services. So Beth, why don't you go into what's going on and what your company is doing and what you've seen in the industry for real-time location services and wayfinding? Sure.
So technology really should be an advocate for the patient experience, and there's so much out there, particularly in healthcare. And real-time locating systems, known as RTLS, helps connect staff and patients with the physical environment. It does this using wireless beacons and antennas throughout the space, and allows you to locate an object or a person from, within 1 to 3 feet. And this, helps provide some efficiency for staff in locating people as well as objects, and saving time. So RTLS has helped enhance the patient experience really by providing information, like for instance, like when the last time a patient had seen a clinician, navigating through a building or campus, as well as being able to help having control over an environment. So some of the examples of this is, for instance, a patient room. A doctor enters a patient room, and on a screen, via his RTLS badge, his name pops up. Hi, Dr. Smith has, is entered the room. There's a log now of when Dr. Smith last saw that patient. The patient now knows that this is Dr. Smith and maybe the first time he's seeing them. As well as now the patient within this room, helps. There's an integration where they can control lighting, temperature, and just the environment around them. And then this even carries over into senior living, for instance, memory care, where, there is quite a bit of fatigue on the staff, where there's a lot of repetitive questions, being asked by memory care patients. So when you deploy an RTLS system, you could tie it to things like digital signage, where John leaves his room to go to dinner. Once John stepped out of the room, maybe he forgot where he was going, or why he's there. So John steps into the corridor, and on the digital signage located in that corridor now, a picture of John's family pops up. So, which now engages John, and then directions, John, you're going to dinner, walk down the hallway, make a left. John walked down the hallway, made a left, to make a left, he now forgets maybe where he's going again. So again, another sign, RTLS is now recognizing John's at this point, again, giving direction. And this really is helping relieve some of the burden and that fatigue on staff members.
Excellent. That's really interesting, right? John, do you have anything else to add to wayfinding and location?
Yeah, I would say it's a great help to all the people that Beth was referring to around memory and stuff, but there's also an augmentation we've been looking at, which is actually getting video coverage and voice coverage throughout facilities, because sometimes there's more you can find out from those kinds of capabilities than a tag on a wayfinding. You can figure out that someone's sitting in a wheelchair somewhere, been there for a long period of time. Perhaps they've nothing to do. It might be a teenager or something, you might find out that the experience you're generating for these folks isn't the optimal by using some of these kinds of technologies. But we're starting to see a lot of interest in how do you help guide folks through a facility and make sure people know where they're going. So RTLS is a valuable investment in that space.
Excellent. And Roger, are you seeing any of this being used in your facility over at Memorial Sloan Kettering?
Absolutely, Jaimie. And I think that for us at the hospital is really about the collaboration. I call it the collaboration triangle that really makes this happen. I think it's a very important collaboration between clinical operations, facilities management, and information systems. And with that, I just want to take the time to give a shout out to some of my very key partners in that journey here at MSK. So Jacqueline Woods, who's our Senior Manager of Enterprise Technology Division, and Karen Roberts, who's one of our Senior Directors of Hospital Operations Solutions. We work very closely together to make sure that that collaboration within these different systems are effective within our patient care areas.
All right, well, thanks, Roger. I hope those people are on and very proud of your mention of them here this afternoon. So great stuff. The other thing that we're seeing, of course, in healthcare facilities, hospitals, et cetera, are voice commands, hand-free, wireless devices, right? I think a lot of consumerization is really bringing this to the forefront. We're doing this in our houses a lot. So Beth, are you seeing this as well in your work? And I know there's a lot of requirements for this, bandwidth, sound detection, right? It's a whole new kind of genre of things that we need to look at in healthcare. So what are you seeing, Beth?
Correct. You know, another technology that's quickly growing in healthcare is ambient voice technologies, and that is tied to, you know, voice commands, hands-free commands, you know, tied into the wireless system. But the way this is being utilized right now is, you know, assisting clinicians or staff members in things like dictation, you know, being able to speak out loud and have voice recordings, you know, which also translate into documentation of records, which saves clinicians quite a bit of time. Things like being able to pull up test results, you know, refill meds, you know, set reminders, you know, for nursing staff, like so-and-so needs a pillow. You know, these are things that you're being able to do via room setups as well as a personal device integration with voice commands for a personal device. And companies like Epic, for instance, I know has recently released Epic Voice, which, you know, is allowing that. I know there's, you know, everyone's spoken of Alexa. You know, there's Alexa Concierge out there, but it's, you know, due to some concerns with privacy that's been slow to, oh, Alexa just started talking to me.
You can't use the word Alexa in your house anymore because Alexa responds every time it hears it, right?
Yeah, she just heard it. So, you know, things like assistance for staff, as well as, again, a patient being able to control their physical environment via voice control. And then also with COVID today, you know, how that works in a touchless environment. So we're seeing more and more requests for touchless environments, and these voice integration and voice command systems are allowing, you know, more of that. So as far as infrastructure into the space, you know, it's another device that sits on the network. You know, so I don't see that playing a huge role as far as deploying that throughout areas.
What you said that interests me is integration with Epic, right? So the EHR providers and the other big software vendors into hospitals are getting into the space, right? We'll hear from John in a second, but Roger, what are you doing in this case at MSKCC?
So at one of our more recent projects, actually one that I was the lead project manager on, is our David H. Koch Center for Cancer Care at Memorial Sloan Kettering on the Upper East Side. And we've utilized all these different technologies that we discussed and will discuss in this conversation in our institution. So wayfinding to us really became our indoor and outdoor navigation system throughout the building, as well as an amenity system, as being able to navigate patients not only throughout the facility, but also show them where the cafe was, or what are some of the programs that are going on throughout the building. And we really wanted to utilize BLE, Bluetooth Low Energy technology, for that, because we saw the benefits of being able to be a lot more flexible. I think in some of our real-time location systems, it's more about the chairside resolution, and it's more about that IR technology, which does have its benefits as far as us being able to manage flow, whether it's our patients or our staff. But for a wayfinding standpoint, we went with that technology instead. And also wanted to just touch briefly on another system that Beth mentioned, which is the patient interface. Right now, we do it as a wired solution. And the reason why we do that is really because we want to offer two different types of functions. What I would call operational in regards to telemedicine, video translation for, translation services, and also nurse call. But we also like to offer the amenity of temperature control, window treatment control, lighting, and also entertainment. And I think the wired side of things right now gives us a lot of control as far as security and everything along with that. So we do have some experiences with those types of technology in our newest facilities.
It's really interesting seeing that, these technologies are getting quickly integrated. And, like you said, Roger, in your newest facilities, you're accounting for these technologies, building them in. So, John, what are you seeing in the market from, say, Microsoft on where this is going, and even your comments, your thoughts on how fast this is going, right? Given where we are.
So Jaimie, thank you for that. Beth, I'm glad you said ambient intelligence. As I'm going to tell you what would have been 3 hymns ago if we had our last hymns, or physical one. We actually released some technology from our research organization that was focused on ambient intelligence. And we've since actually combined our efforts with Nuance. So we've come out with this Dragon ambient intelligence capability, which is we're training the algorithms, and we've been training them over time to do more and more in the various departments. But what it does is you actually put a device inside a room. Or you can do it on a telehealth platform as well. And what it does is it listens to the conversation between the doctor and nurse, doctor and patient, and it basically dissects what's going on in that conversation. It'll actually create documentation for the medical record, which is then presented back to the medical professional to determine if the documentation is accurate or if they want to make changes. If they do make changes to that documentation, the actual ambient intelligence learns over time about how they prefer to do things in the medical setting. And we're starting to see a lot of interest in this kind of a platform. So convenience not only at the patient end, but also convenience for the medical professionals who historically have been going, we called it pajama time. They would do all their work all day and then they'd go home and actually do their medical notes. And this gives them a capability to do that. Hopefully we can help lessen burnout and perhaps, even get a little bit better at the documentation aspects. And then you add to that things like NLP and stuff, which we use naturally to build the notes, but actually we can use it against the notes that get created in the medical record. And we can actually grab some more intelligence out of it. I've got one institute that's doing a great job at building what we call real world evidence for device manufacturers and pharma companies, because they're able to do that NLP against the notes as well as drive it through an ambient intelligence function. But again, like I've said to everyone, give me microphone coverage, give me video coverage in a facility, and we can do a lot with what we call cognitive services in the cloud around computing what's going on and helping and assisting. So those are my thoughts on it, Jaimie.
So Joe, John, quick question on this, and I know I've seen this in the industry as well. When we talk about ambient listening, especially between clinicians, how good or how do you feel about the clinical dialogue that happens, right? We all know that Alexa is very good at giving us a recipe or playing our next song, right? But we know that clinical discussion, and whether it's between a doctor, nurse, doctor, patient, is very, very different than our common English. How have you seen that play out?
Yeah, Jaimie, that's actually one of the main reasons we joined forces with Nuance, because Nuance has a bank of medical professionals they use to help train these algorithms. It is not an easy exercise to train an algorithm in medical lingo and language, and really, what does the word cold mean? It could mean many different things. The person's cold, they had a cold attitude, the room's cold. It can mean lots of things. And so how do you get the sentiment out of the verbiage that's going on and record it? And we're teaching these systems over time by training them through lots of medical procedures that are allowing us to get better and better at it. But that's the beauty of AI in healthcare, is that we can actually improve through machine learning and artificial intelligence the capability of these things. So it's getting better every day, Jaimie, but we still got a long way to go before we'll be anywhere close to what a doctor does. And we'll never replace a doctor. It'll always just be augmentation to them. But hopefully the system, they're learning very fast. It's amazing how rapidly these things develop, right? Once you get them started, and once it can get a knowledge base built, they learn very, very fast, but still a long way to go yet, Jaimie.
Well, I don't think anyone's looking to replace doctors, right? I think the holy grail is, do doctors need to physically direct, whether it's their voice or the typing into an EHR or some of that, or can you have that ambient listening that picks up on, okay, this sounds like a prescription, this sounds like a condition, right? Even once it understands the actual language and the words, what part of the consultation between the patient and the physician is this, right? Whereas as opposed to, oh, my mother had a cold last week, so I have a cold now. Could they pick up on stuff of that nature? I know it's still a long way off.
Yeah. So one last thing on this, Jaimie, and that is that we're not just using live procedures to help train this thing. We actually have used call center calls from people that are calling into medical call centers to train these things. We took 5 or 6 years of call center calls from one very large institute, and we actually trained it so that we could actually understand that a little bit better, try to get some lingo out of that. There were doctors and nurses on the other end of the line. But it's also helped us create efficiency in those call center approaches as well. So there's lots of stuff going on as the algorithms get more and more data. We're going to learn a lot more, and we'll be able to assist a lot of people in the healthcare business.
Excellent. Very interesting stuff. Another thing I want to touch on while we're talking about just the enhanced patient experience, we've been talking a bit about it today, already, is just general technology adoption, right? There's several different generations living out there in society today, and they're all going to hospitals and healthcare facilities, obviously. Perhaps the older generations are going more frequently. What are your thoughts, John, on people bringing their own devices or standardizing on devices, or, I assume generally speaking, the younger generations are the first new adopters to like the next iPhone, iPad, whatever. Yeah. How do you think the medical community and providers are dealing with that?
Yeah, well, how they're working with it, how they should be working with it, Jaimie, is probably a better conversation to start with, and then I'll talk about some experiences I'm seeing. This market is starting to see the effects of consumerization at a mass scale that we haven't witnessed really as medical professionals in the past. What that means is, as this consumer shows up at your medical facility or goes online with you or whatever, they're expecting the same kind of experience they get out of other industries that they use every day. Maybe it be an experience of booking a travel facility or basically getting on an airplane. They're looking for that same kind of coverage and capability from the healthcare industry. So my thing for you would be bolster your security, improve your network capability, so when they walk in your facility, it's a great experience around the access, if you would, to the internet and those types of things. But also be looking for those opportunities to provide them experiences that will set you apart as a health industry, or as a healthcare provider from other players in this market segment. And the one thing to really remember about all this is that the more you can provide them to do on their own device, when they're touching their own device, they're not touching one of your devices. And that's a safety factor because cleanliness on their device is their problem. Cleanliness on a device you provide could become your issue, and we don't want to transmit things. So this could be a very interesting safety factor as well. But that experience is important to attract them as patients, particularly the young ones.
Just to add to what John was saying, is that we're finding, like on the design side with healthcare, is that people are expecting to check into a healthcare facility and have the same experience as if they're checking into a 5-star hotel. And, you know, a lot of that really is driven by technology. So though there is, you know, still generational gap and, you know, with the use of technology, and that gap will close year after year, you know, get a little closer, you know, you still have, you know, seniors who are proficient or somewhat proficient that are using smartphones, and then you'll still have those that are using flip phones. But again, if you know, if someone shows up with a flip phone, a senior who the majority tend to be within healthcare facilities, you know, you can still offer that device, which most healthcare institutions are, and make it, you know, make it simple to use, as long as it's user friendly and simple, you know, pictures instead of having to read through text, you know, touch and brings you to a portal, you know, they're going to use it a lot more. And though what John was saying, particularly now with the spread of infection and germs, if a device is assigned to a single person when you check in, you know, or it's associated with a patient room that they're staying in, then they have it for that time they're there. And then obviously there's still the cleaning protocols after, but you also now have more security on that network. And, you know, you're limiting them or allowing them to stay within the parameters of that technology and places where you want them to go rather than they want to go.
Excellent. And Roger, what are you seeing over at Memorial Sloan when it comes time for bring your own device? And maybe you even want to talk about some of the networking that you've had to have done to make sure and ensure that people with their own devices of a wide variety are able to connect.
Yeah, I think it even goes a step further back than that, Jaimie. It's a unique challenge from a design and construction perspective, to where we're working with the differences and the competition between aesthetic and functionality. You know, there's a lot of different challenges in the built environment when it comes to ceiling designs and the number of wireless access points, the number of BLE beacons, the number of sensors. Then you have to incorporate your ceiling diffusers for airflow, your lighting for just general lighting in the space. And we definitely get into areas where that collaboration that I discussed earlier is key, because everybody has a point of view and everybody has a perspective. So we work together to try to collaborate to make sure that we're still within our code requirements. We're still meeting the bandwidth that we would need to make these systems work. And I think that kind of goes into your question about bring your own device versus what we do here. And right now we're in the business of providing. In our infusion and our inpatient areas, we actually provide the devices that have that patient interface. And again, like to the point Beth made, has a lot to do with security protocols. And John also made that point as well, to make sure that we're controlling who's getting onto our networks, who's getting into the backnet and all the different systems that drive our HVAC systems to allow that temperature control and those different amenities for patients. So eventually you'd love to be in a position where you could provide a space where people could come in with their own devices. But again, that challenge comes into what infrastructure is required and what are the balances between some of the things I've discussed before, amenity versus functionality.
Excellent. And Beth, what are you seeing within networking for these devices and management?
I mean, I think the biggest industry problem is right now, and this is across, you know, healthcare, IoT devices, smart buildings, is the lack of integration between them. That there's so many different systems and they're all standalone and they don't want to play nice with each other, that, you know, the infrastructure becomes cumbersome and, you know, overwhelming to a point where, you know, you can't have all these, you know, you can't have RTLS and, you know, wayfinding per se, and your, you know, patient entertainment, everything all on, you know, in a single place over a single wireless platform, if it's a wireless device, you know, just because Everyone wants you to use their software. Everyone wants their own platform. And, you know, it's become a problem, especially as more and more IoT platforms are deployed and everyone wants them. How many are you going to have? As Roger was saying before with construction, I mean, I did a major medical center recently, and we literally had 14 wireless devices and other devices on the ceiling, 14 different ones, just to support all of the technologies that they wanted. And, it's too much, but that's what it is today. So hopefully we'll see a little bit more integration and, people playing nice in the sandbox together so that, we don't have so many.
Excellent. John, any thoughts?
Yeah, so I get to speak at a lot of design conferences about how to design the next medical facility. And one of the things I continually focus on is, realize that around networking and stuff, there's some major advancements coming, like with things like 5G and private 5G and, what's going to be 6G, when's that going to come along? There's two things I kind of focus on mostly around advancements is the speed of network kind of capability and lack of latency in some of these things, and how to drive that as you design new facilities, as well as, computational aspects on the back end to do things like I talked about cognitive computing. We're getting to the place where quantum will become a realization in the next few years. And as you design a medical facility, you got to think out a few years about what's going to happen to this technology so that you're designing the capability and the pathway toward it. It may not all be mature yet, but we've got to design the future into these types of things as well. And I don't know in New York City where you find room on a ceiling for 14 devices, but bless you, Beth, for being able to do that. So.
Interesting. So before we continue, I want to hit our Q&A chat. We have a few questions from Mithun at the University of Rochester Medical Center, so I'm going to read them out loud. And so first question, how are you seeing healthcare orgs effectively build the cross-disciplinary teams such as nursing, informatics, clinical operations, IT, biomed that are necessary to implement these workflow experiences that are with heavy new technologies? I'm not sure who wants to answer that, but maybe you, John?
Well, I can tell you what I see in the field. I can see that there's a need for that discipline gathering, right? And we're starting to see that. There's actually a concept that's starting to happen out in the field. We do it more around development of technology, from an application perspective, but we're starting to do this thing that's called hackathons, right? And so it's about getting multiple people with multiple disciplines together and working through what that experience needs to look like in a short and condensed time period. And out of that, you get requirements that you can drive what you need to do inside the health facility. We're starting to see that be a very effective model. It's been an effective model in software development for years, and we're starting to see that show up in healthcare systems. It's really helping this cross-discipline along. There's also other roles that are starting to pop up in hospitals that historically hadn't, that are basically fostering this kind of stuff, like a chief experience officer. So someone that's there to design the experience, or a chief medical information officer, someone that's focused on the information technology around how medicine's delivered, right? So there's some new roles showing up. Every year I visit a great user experience or patient experience conference. And what I've noticed over the last 5 or 6 years is we've migrated from people that were just in that department to people that became directors, then there were VPs. Now we got, chief experience officers. So there's a whole side of the business developing around how do we present those experiences to both our care providers and our patients.
Excellent. Roger, Beth, if you have anything to add, please do. If not, we go to the next question.
Yeah, I think that's kind of where I started the conversation, Jaimie, and I think it's very important to have that collaboration and communication. MSK has definitely invested resources into exactly what John mentioned. And when I mentioned Karen Roberts, who's our Senior Director of Hospital Operations Solutions, that's really the liaison, that's the key in between bringing these entities and all of these different groups together to kind of achieve the same goal.
Interesting. Yeah, it's a new way of working for some people, and to your point, even creating new jobs for new people with a new perspective on what the hospitals and the facilities should be doing, right? like one thing Beth said earlier is 5-star hotel, right? I know that there's sort of this convergence of the hospitality industry and the hospital industry, feeling that, you know, the hospitals have something to learn from hospitality because, again, first off, the irony is the word hospital starts with hospitality, but also, you know, they see their businesses as starting to be very, very similar in certain ways. So moving on to the second question from Mithin. How are you seeing healthcare orgs reorganize and restructure their traditional support models to support these new technologies, integrations, and associated infrastructures such as RTLS, mobility, VoIP, after the initial implementation? So I don't know which of you want to take that from more a support end.
Yeah, I think that what we're seeing in our institution is a lot of product owners. We're really putting the resource into individuals to own not only just the end result of a system, but the implementation, the design, all the other aspects that come along with it. So as an example, on our David H. Koch Center, I was the lead project manager that was dealing with the construction side, the design, and the engineering side. But I had a partner within our health informatics group that was a product owner of the RTLS system, was a product owner of the wayfinding system, and it helped bridge the gap and it bridged those understandings. So I know that we're doing it, and I believe that that's pretty much the way you have to do it moving forward.
Hey, can I say something here, Jaimie?
Sure, go for it.
Roger, I'm going to actually put you on the spot here in a second, too. One of the things I see as the biggest barrier, frankly, to this change we're talking about is the way projects get financed inside of healthcare and how they're very focused on certain specific projects, but there's very little straight line infrastructure kind of financing. I recognize that even when I was the CIO. And I'm wondering if your financial approach around budgeting at the Institute has changed in relationship to some of these cross-functional kind of things.
Yeah, I think that what we've seen is you really need energy behind the outcome of the system. I think in a lot of times, and Beth, correct me if I'm wrong here, there's a lot of these systems that you really can't develop a return on investment when it comes to it, dollars for dollar. But what you're able to do is you're able to create sort of the future continuum of what you want to become your healthcare practice and how you want kind of these things to work out. So I think from a budgeting standpoint, John, to answer your question, I think we've seen the realization of where healthcare is going and how these technological advances really elevate the patient experience, elevate patient outcomes. And I think we as an institution have seen the importance of that beyond dollars and cents in some cases.
Right. I'll just add to what Roger and John both said this really is, technology is an organizational change and, how it's going to be managed. And we saw that years ago when voice over IP became more prevalent and, that you didn't have any longer the telephone guy and the data guy, now it was all one and it was all one job. And we're seeing it today with, for instance, PoE lighting. Where does PoE lighting fall? Does it fall to the network guys? Does it fall to the facility managers? And it's the same type of thing. Like you really need to figure out, or within your organization, who's going to manage these technologies, who's going to support these technologies. And then most importantly is getting the infrastructure in to make these technologies, expandable, scalable. And once you go to that voice over IP platform, that really does allow you to grow all these technologies, all of these IoT or MIoT technologies sit on this, PoE network. So, that's really where I think the industry is going. And, you need to have someone in charge of your healthcare facility that has, is not afraid of technology and has a vision for the facility.
Interesting. And on that note, I know we're starting to talk about cost. A lot of the technologies we're talking about today, do we have any insight into cost? Are they large scale budget items, or, and some of these things a little bit, capital budget, operational budget. How do we feel, maybe Roger, do you want to take this question of, as you're building out these things, what's the cost? Are these strong or high financial burdens, or are why don't you give us your thoughts on that?
Well, I think it goes back to the collaboration piece, because, installing one of these systems at the end of construction is a lot more expensive than if it was a part of the initial idea and foundation of your design criteria. And I think that a lot of the energy that we're putting into that collaboration and into these groups don't allow it to be as much of a financial burden as you would trying to catch up at the last minute. I mean, obviously, technology is moving at a rapid pace, as we all know. So there's always going to be nuances, but it's about trying to understand in the basic criteria, what is your maximum flexibility and what is the time frame that you're looking to be able to allow this facility to be flexible enough to accept new technology. So I think that was kind of a rounded way of answering your question, but I think that it's not high dollar from what we're seeing, but we do know it as being a very bigger issue later in the construction phase, where you're doing a lot of deconstruction in order to put something in.
Just to add to what Roger was saying, where it may not be high dollar infrastructure, and he's correct, but in a healthcare facility, you start looking at things like, well, what serves this space better? Is it a large IT closet that, that will house that technology, or a patient room that's constant revenue? So that's really always the struggle, where, IT needs that space in order to provide like all these systems. But, again, we're always arguing against, well, a patient room generates revenue for the hospital, so that's a constant fight on the consultant side once we're setting up these facilities. And obviously that's always looked at as a cost implication.
I could add something to that. I guess the question you have to ask yourself, Jaimie, at some point is, what is cost? I mean, if you're not building experiences that are going to attract patients and doctors to your operation, then the cost could be very, very high if you're not willing to spend those dollars to do some of this kind of stuff. Because you could be the shopping mall of the year 2000, where it was great to be one in the 80s, but there's no one going to those anymore. And so you want to be careful about, when you look at cost, you also got to look at the benefit side of the conversation. And when I go out and speak at a lot of these conferences for building the future healthcare system, I always challenge the architects. But I say, why do you design a hospital for a 50-year life cycle? We used to do that with data centers, right? But technology is changing so rapidly now in the data center space. We design a data center for 12 to 14 months. And we turn it over and do something new. Now, it may be lesser budget to build it the first time, but we'll spend that budget over time. We'll basically spend it on refreshing as technology changes. And I always challenge the architects of, think about this from a perspective of, maybe you want to design for a shorter life cycle and revamp it every so often, right? So I know I could say that because I don't have to design it that way. I'm not an architect, but
Excellent. So we got one last, I'm sorry, go on.
I was just going to say one other story that I'd like to tell is another New York City major healthcare institution. They have a campus in Manhattan. They have obviously an old hospital and a new hospital that they've built. And, this all ties back to HCAHPS. The new hospital has new technology, has iPads and patient integration within each of these rooms, and the older hospital doesn't. With all these amenities like a 5-star hotel, the HCAHPS scores, you really start to see a difference. So even though things like, the food is the same, the doctors are the same, the nurses are the same, it tastes better in a nice new facility with, an iPad and a 75-inch TV, than in the older facility. That, somehow you perceive yourself as getting better care in these newer high-tech facilities than you do in the older facilities. So that also, it becomes a consideration when, HCAHPS tie back to reimbursements. You want to attract the talent, and obviously you want the patients, to choose your institution.
Hey, Beth, I wanted to add to that. I had a very interesting experience. I was helping on a redesign of a health facility, and somebody was talking about the experience in their waiting room areas and their lobby areas. And I said, well, where do you like to go in your life? What is a place you'd like to go to that you like the experience you get in a building facility? And the answer from 3 of the executive team was, I like the spa. I said, so why don't we go get the people that design your spa and have them come in and figure out what they can design in a healthcare facility? So you can see that cross-pollination of it's about the experience, because we got to attract these patients and medical professionals.
And Jaimie, I'm going to have to chime in on that one, because I think that that's one of our biggest challenges. Definitely not every job is a brand new ground up construction project, and our renovation, that's really where the money is. I mean, it's really about how much can you upgrade this place? How much money are you willing to put into it? And it's an ongoing challenge to make sure that we have that continuum of care, because not everybody's going to get an appointment at the new facility, but they just might. And if they do, and they come back to the old facility, that's something that we really have to deal with from a patient experience standpoint, and also staff experience for that matter. I think that's also an important point to point out, is that you want to make sure that everyone feels that things are equitable across the institution.
Really interesting seeing the crossover between, like I said, hospitality and hospitals, right? To John's point, let's get the same kind of design, the same designers to do sort of a same design of a spa, of a 5-star hotel, right? Other great things. I can imagine a few things that I would like to see in a hospital, but that will take too long to talk about here today. But it's just really interesting to see how that whole mind shift is changing, throughout the industry, and how that helps hospitals stay competitive, right? We know our hospitals are also trying to earn revenue, earn reimbursement, right? They want more patients to visit them than their competitors, especially in New York City, right? We have so many big hospital systems here in the city that becomes very competitive, right? Moving to the last question in the QA before we switch gears a bit. Regarding mobility and clinical communications, meaning VoIP, secure texting, alarm notifications, are you seeing more healthcare orgs go down an EMR first strategy or choosing a best of breed vendor? Epic is a recent entrant in this space, making this quite the dilemma for many Epic customers, right? And we kind of know Epic's point of view is, they want to own the entire customer experience, I guess, end to end. I don't know, I don't work at Epic, but it kind of appears that way to me. So what are you guys seeing? A best of breed approach or a more platform approach? I don't know who wants to go first.
Well, Jaimie, I get to see a lot of health systems, so maybe it's probably best if I approach this first. What I'm actually seeing is kind of a split, right? I see some organizations that are kind of saying my EMR is a valuable part of my system, but I've got to build an experience that's beyond what the EMR provides. And then I have other healthcare institutes that are so tied into their EMR provider that they think that they're going to let their EMR provider produce all the experiences. And, you can look to other industries for indications around stuff like this. Like if you look over in manufacturing and in the wholesale distribution industry, we had ERP systems, which are similar to EMR systems in the healthcare space for years. But then there became all this need for customer relationship management systems and supply chain management systems. And, I think it will evolve over time. There are some big players that built some of those capabilities in those other industries that we might see EMRs get into here. But it's all a question of how quickly can one provider of that EMR space produce some of that capability, right? And that's going to be key to the adoption level between an EMR or going a best of breed kind of model. But I'm seeing a real kind of split in the market space.
Interesting. Maybe it's still evolving, right?
Yeah, I think it is.
All right. Moving right along, we were just talking about patient experience or enhancing the patient experience for the past 45 minutes. I'd like to switch gears a little bit and talk more a bit about telemedicine, especially in this new world of the pandemic. We're starting to see a lot more people do telemedicine, and it's bringing a lot of interesting transformations within our industry, especially with the way facilities are designed and actually the usage of space in facilities. So Roger, you had some thoughts, I know, about how to design a right environment for telemedicine and how you're doing it and what your thoughts are from Memorial Sloan.
Yeah, from a design and construction standpoint, we find it to be probably the most easiest form of conversion. You put a camera, you put a computer, you get a network connection. From our perspective, you're good to go. But the problem is that the challenges still extend to our clinical partners, and our side of it is really just the beginning of what makes it effective. A lot of the challenges that I know that my colleagues are experiencing is about the challenges of conducting a virtual visit and really getting everybody on board that needs to be on board, as far as the fellows or the nurses and the physicians and the whole clinical care team that really makes that a seamless endeavor. We talked earlier about the expectations of people and patients and whomever within this world. They want a seamless experience. And then another issue that I know that we experience is really about the technology readiness of the patient themselves. Like Beth mentioned earlier, you have a lot of people who are very tech savvy, but then you have a lot who aren't. And how do you flex your scenario in order to meet the needs of someone that is very tech savvy versus someone that isn't? So from our perspective, as far as the design and construction side of things, it was a very easy transition for us to get ourselves telemedicine ready. But there's a lot of challenges that go beyond that. It takes a whole group of collaboration within different areas of our institution in order to make that happen.
Right. So yeah, I figured with lighting, and there's a lot of things such as lighting, camera availability, what kind of cameras to use, things that we almost take for granted these days. So John, what are your thoughts, or what are you seeing within how people are designing facilities now for telemedicine?
Well, I think the first thing I'll tell you, Jaimie, is one of the biggest things we had to do right at the beginning of the pandemic was try to locate cameras for a lot of folks, right? There was a shortage in webcams and stuff, so people could actually participate in the telehealth, televisit space. I think what's interesting about telemedicine and telehealth is it's gotten to be the new norm, because people have been trained. They have to be, for safety reasons, staying outside the facility. Both medical professionals and patients have been trained to use this experience. And in real estate or in retail, it used to be location, location, location. Well, now it's more, how do I create an experience, whether I'm physically with you or not? And how can I deliver as much as I possibly can over telehealth? So I see it very interesting. Like before pandemic, it was, if we were talking about telehealth, it was, how do I fit it into my normal practice as a doctor? How do I not leave my practice and tend to my folks that are in the hospital? How do I put it in a separate room to actually make it like an exam? And now people are adapting to, the home-based scenario where you hear dogs in the background. Sorry, Beth, I heard your dogs earlier. Or you basically have interruptions that have become traditional in this day and age. And I think in the facility space, it might reduce some of the needs for some of the facilities we have. We might find more medical professionals in the long term doing telehealth, particularly if some of the reimbursement stays the way it is through the pandemic era, and some of the regulations about crossing state boundaries on certifications and stuff stay the way they are. So I think there's a lot of legislation that's going to actually draw into that conversation as well.
Excellent. Beth, any thoughts?
No, I agree with what John and Roger said. I mean, what we're seeing in design of facilities, including, as we've talked about hospitality, hospitals or healthcare institutions are actually now building hospitality suites to house, whether it be a visiting doctor or a patient or patient families close to the healthcare institution. So with that, they're taking the opportunity to put telemedicine or telehealth equipment into a hotel room. And, you know, that brings, again, like, you know, you have things like privacy, like everyone's always concerned about privacy when it comes to telehealth. So aside from like lighting and equipment, you now have also sound barriers that, you know, you don't want the person in the room next to you listening to you on the phone with, you know, on the monitor with your doctor or clinician, other family members. So, you know, it's going to continue to grow, as we've seen, and COVID has definitely leaped it ahead, probably quite a few years to acceptance, you know, out of necessity rather than willingness, I think, during these times.
Interesting, yeah. So, Roger, how has your facility and changed the way they've done capacity management and looked at space and, you know, managed the physical space during as you guys are expanding into telemedicine or, you know, doing more telemedicine?
Yeah, I would say initially, you know, because COVID, you know, hit everyone really hard. I mean, I think that's like the understatement of the last hour that we've had talking to each other. Really what we did in the beginning was we pivoted to kind of help our capacity, help the institution. So what I mean by that is we created a social distancing environment. So instead of having people sitting in waiting rooms, we used that additional capacity to help spread people out as far as the clinical teams, as far as the patients that were in the building. But I know moving forward, and I think this is important in pretty much all healthcare institutions, is you start to look at exam room space and you say to yourself, is this the same revenue generating space that I initially thought it was whenever you planned out your footprint? And I think that we're looking at various ways to be flexible and to transition these spaces into more relevant spaces for the new environment. I think that it had a lot to do with the forward thinking of our institution of what we call our 1MSK criteria, where we look at rooms for functionality and flexibility just in general. This was prior to, you know, a global pandemic. This was kind of saying to ourselves, you know, what would it take to turn an exam room into an infusion room? What would turn an exam room into a procedure room? All those different thought processes allowed us to be pretty much what I would consider on the forefront of, you know, being able to adjust in the period that we're in right now. But I think initially what we did was we dealt with the issue we had at hand, and we used that access capacity to help spread people out and allow feeling of comfort to our patients and our staff based on what we knew the criteria of this pandemic was. But then moving forward, I think we're going to take a hard look at spaces and maximize that flexibility that we put into it from the beginning.
Interesting. Any thoughts, John?
Yeah, it's interesting. We talk about the physical space we think of as a hospital, but it's affecting a whole bunch of other things in the healthcare system. I can imagine your call center operations, Roger, have had to spread out a little bit. You might have had to send more of those folks home as well. And when you think about a facility, you know, one of the things that's starting to be built into every healthcare system's brand is safety. And you want to demonstrate to your patients and to your care providers that the experience you're going to provide them inside that facility is safe, that I have distance between folks, that I have an ability to isolate air chambers and things like that, that when I actually need to put a quarantine area together for COVID patients, I can do that effectively and manage it. And, you know, safety is going to become a key factor of the brand function of these health systems. And so you'll be measured not just on the quality of care, but also the safety factors and the experience you're producing. And I think that's a drastic change for this market segment. And it's going to change every facility that delivers healthcare in the United States and the world.
Excellent. And Beth, any thoughts?
No, just, you know, to add to what John was saying is that, flexibility in being able to provide that care, whether it be a pandemic or anything else, it really is key. I mean, we were involved in a lot of the alternate care facilities that went up once COVID hit, and the hospitals just didn't have the capacity to handle the patients or what they were expecting, during this wave of patients and healthcare needs. And now that things, have kind of settled a bit, healthcare institutions are really looking at how do we build that flexibility into our institution in order to handle whether it be the next wave or, unfortunately, maybe the next pandemic, and be able to keep that within our facility rather than a tent in the parking lot, more of almost like a plug and play type of thing where maybe even you have a single patient room, but that room has the capability to easily convert to a 2-patient room in order to handle that overflow. So I think, again, flexibility and scalability is always key. And, though you're planning ahead and there are cost implications for that, rather than scramble and have, again, sites and tents set up throughout the city or, Long Island, you could handle it within. I mean, even we've heard of institutions looking at their parking garages where, again, instead of setting a tent up in their parking lot, they could somehow outfit their parking garage to easily be able to convert to handle patients.
Very interesting. People are being very resourceful and thinking new ways of the spaces, right? Given the large spike in demand through COVID, as well as telemedicine, which also redefines how people are going to be using the space. I know we're at the end of the hour. We still want to spend about another 10 minutes with everyone to discuss yet another topic that we had prepared on this panel agenda. So if you want to bear with us for another 10 minutes, we're going to talk now about infection control and how some disruptive technologies in healthcare facilities are managing infection control, right? So one of the big things is safety enhancements, right? There's a whole bunch of different things that we can do now with some disruptive technologies. And I know, John, I think you've made some points on it to me earlier that you had some thoughts on how safety enhancements, how disruptive technologies can enhance safety as well as do things such as bring more brand recognition for providers. So John, why don't you give us your thoughts?
Yeah, Jaimie, I mentioned that I do think that safety in your brand is going to be extremely important in the future. You don't want to be that health system that is known to actually spread the infection because you haven't built safety into your operations. And we're seeing some very interesting advanced technologies. Like, I don't know if you noticed, but at the beginning of the pandemic, there's a company out there, and I'll forget the name of it, that has a thermometer that you can take your temperature, and it tracks people's temperatures around the world. It could actually show you indications of where COVID was showing up before anyone else. We're starting to see some of that kind of technology find its way into the return to operations or return to work, if you would, in the health systems. If you've entered many health systems recently, quite often they'll actually have a temperature check at the door. I actually saw a device the other day by a company that's actually got 4 biometrics. You walk through it like you do a scanner at an airport, and it's got 4 biometric signals it picks up while you're walking through it. And in 9 seconds, off a cloud computing capability, they can determine your risk factor for actually having COVID, if you would, and demonstrating that they can isolate those people pretty quickly, because it's more than just temperature checks. It has a lot to do with visuals of the people. There's all kinds of different things. And it's fascinating, some of the technologies. One of the things I find interesting about the technology industry is give us a challenge, and somehow we'll find a way to get past that challenge. And so you'll start seeing some of these technologies show up. That technology I was telling you about actually started because they wanted to get people to return to like NFL football games and to sporting events and things like that. But we're going to start seeing a huge uptake of that kind of capability inside the healthcare facilities. And it's going to be imperative to drive safety into your brand if you don't want to see leakage because you're known as the hospital that, you know, people don't want to go to because there's an infection control issue there.
Right. In fact, our last HIMSS call, I think last month, was a lot about temperature sensors, where you could put a temperature sensor like mounted somewhere in the hospital like lobby, and then it could monitor everyone at the same time and kind of pick out the people who are at risk. It was very interesting. So, Roger, what are your hospital doing for infection control, and what kind of devices are you using for monitoring, and how does MSKCC see their brand as being a safe brand of a hospital with respect to infections?
Yeah, I think that it, you know, I hate to make it sound like we're like the forward thinkers of America, but I mean, I think our institution had a very strong understanding of infection control from very early on. I mean, pretty much, if I use the Koch Center as an example, in all of our infusion areas, we have hand washing sinks that are outside of the space. And it was something that was part of our 2013 planning, 2013 through 2015 planning, because we wanted to focus on the experience. And one of the pillars within that experience was always safety. I think that at this point, you know, the different types of technologies that are coming forward now, as far as, like we mentioned, temperature checks or contact tracing, utilizing RTLS system to be able to do that real time in the hospital itself, are things that we're looking to do moving forward. But I have to say that a lot of these concepts was a part of our patient experience, and it's kind of just us taking it to the next level of where we are right now with the pandemic. But I have to say it's always been kind of a part of our criteria.
Excellent. Sorry, I just needed a snack there. So, Beth, what are you seeing as well from your firm and your point of view on what kind of sensors you guys are using and what safety enhancements you're having with infection control with those devices?
You know, some of them are not new, and they've been out there for quite a bit, particularly in healthcare institutions. As Roger had mentioned, you know, hand washing and sanitizing is so important in not spreading HAIs. I saw a study where using RFID just on hand sanitizer that, you know, was now tracking when clinicians and staff before and after they met with a patient that they were sanitizing and washing, and they actually saw a decrease of 217% in hospital-borne infections just by monitoring, you know, hand washing and sanitizing. So that's huge. Now, in a time of COVID, you know, we're seeing that taken to the next level, where you have a lot of cameras deployed throughout spaces, and those cameras can, you know, do a few things. And, you know, some people have mixed feelings about it. It's a little Big Brother-ish, but things like, you know, is someone wearing a mask? You know, is someone within 6 feet of another person? And, you know, these cameras can recognize this using, you know, AI technologies, and then it sends, you know, maybe it sends a notification to a manager. You know, again, a little Big Brother-ish, but the idea is just to try to keep everybody safe. You know, we're also seeing a lot more digital signage. So digital signage outside of rooms, you know, whether it's showing capacity of that room and whether that room is at capacity, whether the room has been cleaned and sanitized after it was used, you know, and ready to turn over. So, you know, these are the types of technologies we're seeing a lot more touchless technologies, you know, doors, entry points. So again, like clients seem to be asking, you know, what's new and available out there. And some of this is existing technology and some of it is new or just being utilized more.
And what's interesting to me is it goes so many spots, right? You said, Beth, touchless doors, right? And we kind of had those at, I remember, grocery stores, 40, 50 years ago. So that's obvious one. But, hand sanitizer and hand washing stations that have, IoT and that, I think that's fantastic, right? You could almost combine that with some of the contact tracing and really know who's washed their hands and who hasn't. Right. And for how long, right? Do they just like put their hands under the soap for 30 seconds, for 2 seconds like my kids do, or do they really take the task in earnest? Right. So.
And then even just, streamlining the whole check-in process where if you're pre-registering, whether it be a healthcare facility or just an office building, pre-registering, you have maybe a QR code on your phone. You now can enter the building touchlessly. You now could get on an elevator touchlessly, and get to the floor needed. And even providing that, because it's taking to the floor you're going that you've registered for, that provides like an extra level of security.
And it goes back to wayfinding, right? So a lot of these technologies and solutions we're talking about today have more than one purpose, which is really interesting, right? And I think if you really take a look at a lot of technologies over the course of history, a lot of technologies were intended for one reason and then got adopted for a second reason as well. And I think that's really what makes technology stick and be as transformative sometimes, because it does have more than one purpose, well beyond the original intent. So with that, we just want to kind of finish up here. In closing, I wanted to see if you guys each one of you had anything left to say or any closing thoughts. Maybe you, John.
Well, I'll start with the favorite quotes from Kathleen McGraw, who is a peer of mine. Everybody stay safe and wash your hands. That's what she tells me every time I'm on the phone with her. So
Kathleen ends all her calls with everyone, wash your hands, wash your hands, wash your hands. So that's great advice, and it sounds like Beth and her technology can actually test whether you're washing your hands, and we're all going to get a report later. So Beth, anything in closing?
Yeah, I'm just going to say that, continue to embrace technology, that it's your friend. Right. Don't be afraid of it.
Don't be afraid of it. It's here to help you, right? And lastly, Roger.
Yeah, I'd just like to say that I think that, me personally, I'm truly excited about the potential of these different technologies in healthcare. I think there's so many advancements and different things that could be achieved to enhance the patient experience and also enhance patient outcomes. But I think that we also have to continue to advance as people and pay close attention to the social injustice and the things that are going on in the world today, and do what we can do individually to make it a better place.
Absolutely. Well said, Roger, right? And I think we're going to even possibly see future HIMSS content and HIMSS webinars across different chapters more socially aligned to talk about some of those issues that you were just bringing up, or those thoughts you were bringing up. So thank you. Just want to say thank you to everyone. A little personal note, I'm going to embarrass Beth. Beth and I have known each other since we've been about 3 years old. So this is the first time we've ever done something work-wise together. Our families are really, really close with each other. I'm sure our moms are watching, so hi, Mom. With that, hope everyone learned a lot today. This was really exciting and fun for us. And have a great day.
Bye.
All right, thank you. Bye.